This video will go over ventricular asystole as well as CPR, defibrillation, and an implanted cardioverted defibrillator. So first we're going to talk about ventricular asystole, also called ventricular standstill. A lot of times in movies or whatever, you hear lay people call it flatlining. It's the complete absence of any ventricular rhythm. There are no electrical impulses in the ventricles and therefore no ventricular depolarization, no QRS complex, no contraction, no cardiac output, and no perfusion to the rest of the body. The ECG strip you see there is ventricular asystole with one idioventricular complex. So there's one little firing there that showed up on the strip, but that straight line is what we're talking about when we're talking about asystole. The patient in ventricular asystole has no pulse, respirations, or blood pressure. The patient is in full cardiac arrest. Asystole can usually result from myocardial hypoxia, which may be a consequence of advanced heart failure. It may also be caused by severe hyperkalemia and acidosis. If P waves are seen, asystole is likely because of severe ventricular conduction blocks. Treatment of ventricular asystole includes high-quality CPR and following a CLS protocol. When cardiac arrest occurs, cardiac output stops. Priorities involve maintaining a patent airway, ventilating with mouth-to-mask devices or with a bag valve mask, and starting chest compressions. Cardiopulmonary resuscitation, or CPR, or BLS, must be initiated immediately when asystole occurs. When finding an unresponsive patient, confirm unresponsiveness and call 911 if you're out in the public, or initiate a code if you're in the hospital setting. Gather AED in public or defibrillator before initiating CPR if you are alone. Guidelines for CPR have changed from ABC approach to the CAB, compression, airways, and breathing. You want to check for carotid pulse for 5 to 10 seconds. If the pulse is absent, start chest compressions, 100 to 120 compressions per minute at a depth of 2 inches, no more than 2.4 inches. Push hard and fast. Make sure that the chest, avoid leaning into the chest after each compression to allow for full chest wall recoil. Maintain patent airway. Ventilate with mouth-to-mask device or bag valve mask, giving rescue breaths at a rate of 10 to 12 breaths per minute. If an advanced airway is placed, the patient is intubated. One breath should be given every 6 to 8 seconds, which would be equivalent to 8 to 10 breaths per minute. Ventilation compression ratio should be maintained at 30 compressions to 2 breaths if advanced airway is not in place. Limit interruptions and compressions to less than 10 seconds. When possible, compressors should rotate every 2 minutes to maintain effective compressions. Your book lists some of the different complications that can occur with CPR that you want to review. As soon as help arrives, place a board under the patient who is not on a firm surface. To make room for the resuscitation team in the crash cart, ask that the area be cleared of movable items and unnecessary personnel. When the AED or defibrillator arrives, do not stop chest compressions while the defibrillator is being set up. If trained to use the AED or defibrillator, apply hands-off defibrillator pads to the patient's chest and turn on the monitor. So you're going to apply the pads, whether it's an AED or you're on the floor and you have the pads, the defibrillator pads, you're going to apply the pads and let the machine monitor the patient's rhythm to see if a shock is advised. If the patient is in VFib or pulseless ventricular tachycardia, the immediate priority is to defibrillate. Defibrillation is an asynchronous countershock. It depolarizes a critical mass of myocardium simultaneously to stop the re-entry circuit, allows the sinus node to regain control of the heart. After defibrillation, CPR is resumed. CPR must be continued at all times except during defibrillation. One thing to note is that defibrillation is not used for asystole. The purpose of defibrillation is disruption of a chaotic rhythm when the SA node signals, allowing the SA node to signal a restart. So with asystole, with the flat line, there's no rhythm to restart. So asystole would not indicate the need for defibrillation. Defibrillation, again, is used for VFib and pulseless VTAC. Before defibrillation, loudly and clearly command all personnel to clear contact with the patient and the bed and check to see that they are clear before the shock is delivered. Deliver shock and immediately resume CPR for 5 cycles or about 2 minutes. During the 2-minute intervals when high-quality CPR is being delivered, the ACLS team administers medications and performs interventions to try and restore an organized cardiac rhythm. An emerging clinical practice is to allow and encourage family to be present during resuscitation attempts. This can be a positive experience for family members and significant others because it promotes closure after the death of a loved one. Although there may be staff resistance and some limits to family presence, overall it is beneficial practice that should be considered in all resuscitation attempts. All right, next we're going to talk about AEDs, or automated external fibrillations. The American Heart Association promotes the use of AEDs for use by laypersons and healthcare professionals responding to cardiac arrest emergencies. These devices can be found in many public places. The patient in cardiac arrest must be on a firm, dry surface. The rescuer places 2 large adhesive patch electrodes on the patient's chest in the same position as for defibrillator electrodes. The rescuer stops CPR and commands anyone present to move away, ensuring that no one is touching the patient. This measure eliminates motion artifact when the machine is analyzing the rhythm. So when the machine, we set the machine up, we turn it on, we get the patches on the patient, and it says that it's going to analyze rhythm. We don't want anyone touching the patient, right? Because that's going to distort what the machine is reading. After rhythm analysis, which may take up to 30 seconds, the machine advises either that a shock is necessary or that a shock is not indicated. Shocks are recommended, again, only for VFib and pulseless VTach. If a shock is indicated, issue a command to clear all contact with the patient and press the charge button. Once the AED is charged, press the shock button and a shock will be delivered. The rescuer then resumes CPR until the AED instructs to stop CPR to analyze the rhythm again. Cardioversion, we talked about a little bit. Again, it is a synchronized shock used for new onset AFib or electively for stable AFib that is resistant to medical therapy. It's used in emergencies for unstable ventricular or supraventricular tachycardias or tachydysrhythmias, and used electively for stable tachydysrhythmias resistant to medical therapies. Defibrillation, again, is an asynchronous countershock that depolarizes critical masses of the myocardium simultaneously to stop re-entry circuit and allow sinus node to regain control of the heart again. AEDs we went over. So continuing on here, your book talks a little bit about implanted cardioverter and defibrillator. The implanted cardioverter defibrillator is indicated for patients who have experienced 1 or more episodes of spontaneous sustained ventricular tachycardia or ventricular fibrillation not caused by a myocardial infarction. On page 688, you have a chart 34-7 that has patient and family education regarding the implantable cardioverter defibrillator that I would like you to review on your own. In addition to being implanted in the patient, there's also an option for a lightweight automated wearable cardioverter defibrillator. It's a vest-like device that's worn 24 hours a day, except when the patient showers or bathes. So it's an external device that can provide a shock, cardioversion, or defibrillation if needed. So go ahead and read these questions and then pause while you're thinking about it. Go ahead and hit play and I will give you the answers again. So for this question, what is your priority intervention? The answer is oxygen should be administered 2 liters per nasal cannula. The correct answer is B. The physician may perform vagal stimulation such as a carotid massage, which may be successful in terminating the dysrhythmia. However, it may only be temporarily successful. Oh. Sorry about that. The correct answer is C. The appropriate medication to administer is adenosine, which is the drug used to treat SVT. The nurse should give the medication as ordered to include 6 mg IV over 1 to 3 seconds, followed by a 20 ml saline flush. It may be repeated in 1 to 2 minutes if necessary. The nurse should monitor the patient's heart rate and rhythm carefully after administration. Be sure to have a crash cart available because a short period of asystole is common after administration. Bradycardia and hypotension may also occur. The correct answer is C. If SVT is continuous, the patient should be studied in an electrophysiology laboratory. Preferred treatment is radiofrequency catheter ablation. Radiofrequency ablation is a procedure that can cure many types of fast heart rates. Using special wires or catheters that are threaded into the heart, radiofrequency energy is targeted toward the areas causing the abnormal heart rhythm, permanently damaging small areas of tissue with heat. The damaged tissue is no longer capable of generating or conducting electrical impulses. If the procedure is successful, this prevents the dysrhythmia from being generated, thereby curing the patient. The correct answer is A. AFib is the most common dysrhythmia seen in clinical practice. It is responsible for a third of hospitalizations. Hospitalizations for cardiac rhythm disturbances. Patients can live with this dysrhythmia, but most are treated with anticoagulation therapy to avoid possible blood clots. The correct answer is D. Current ACLS guidelines recommend administration of oxygen and observation of the heart rhythm first, followed by administration of an IV antidysrhythmic agent such as amiodarone mixed with dextrose 5%. Synchronized cardioversion would be the next step. CPR and immediate defibrillation would be used only to treat unstable VT. The correct answer is A. Many times patients are found to have AFib and they may be asymptomatic. While some patients do live with long-term AFib, they need to be anticoagulated to decrease the risk of embolus formation due to the irregular cardiac rhythm. AFib does not cause death of the heart muscle, nor does it cause the cardiac output to increase. Cardiac output will decrease due to the shortened fill-in time in the atria, which contributes to the development of heart failure due to altered conduction. While monitoring the patient is appropriate, it is not the best response to help educate the patient on the process of AFib.